Infertility is a growing problem all around the world, affecting 48.5 million couples globally. The male factor could be contributory to infertility in 30 to 40% of the cases. Azoospermia is defined as the absence of spermatozoa in the ejaculate, present in 10 to 20% of infertile men. Causes could be pretesticular, like primary or secondary hypogonadism, prolactinomas. Testicular causes include obstructive and non-obstructive azoospermia. Among the testicular azoospermia, the obstructive causes is defined as obstruction of sperm delivery anywhere along the course of the male genital tract, yet with normal spermatogenesis within the testes. Non-obstructive is defined as testicular failure to produce sperm due to various factors. Men with obstructive azoospermia have normal-sized testes and normal hormonal profiles. Non-obstructive are usually characterized by testicular size decrease and significant increase in serum FSH. However, in many cases, testicular biopsy is needed to make the final diagnosis. Of course, among the causes of obstructive azoospermia is obstruction along the course of the male genital tract, starting from the epididymis with infections, tuberculosis, cysts, or tumors, then the vas with congenital, bilateral, or unilateral abscess, and also inflammation, followed by the seminal vesicles, where the vas joins the seminal vesicles, could be hypoplastic or agenetic, and it could contain cysts, and finally the ejaculatory duct and the prosthetic utricle cysts and Mullerian duct cysts. The seminal vesicle and ejaculatory duct obstruction, here the semen is characterized by the obstruction when it is proximal to the ejaculatory duct, the normal volume of the ejaculate, when it is proximal to the ejaculatory duct, because usually the seminal vesicle is responsible for the main volume of the semen. The ejaculate volume will be low when obstruction of the ejaculatory duct exists. Regarding imaging, the differentiation of obstructive from non-obstructive causes will be the main goal of imaging, because surgical treatment is usually offered in obstructive cases. MRI can be complementary for the detection of detailed anatomy and obstructive factors, and it can be helpful for characterizing indeterminate features on ultrasound. Among the advantages of MRI are the detailed characterization of the normal and abnormal scrotal contents. It's not operator dependent, has wide field of view, and it's not invasive like transrectal ultrasound. It has been reported that diffusion parameters, mainly ADC value, can be a useful marker for testicular function, as we will see. The aim of our work was to show the usefulness of magnetic resonance imaging in the evaluation of infertility and distinguishing obstructive from non-obstructive azoospermia. It was a comparative study among the andrology department and MRI unit. And it was it was 20 patients, the population study. All patients were subjected to full medical history, family history, past history, surgical and drug history. Clinical examination was done in the form of general examination for hair distribution, recession of hairline, gynecomastia, build and muscle mass. Local examination was palpation of the testes and the presence of varicocele and the consistency of the vasa. Of course, semen analysis was done, hormonal profile, and testicular biopsy finally. This is the Johnson score for the level of spermatogenesis, where a score of 10 is full spermatogenesis, and a score of 1 is the absence of seminiferous epithelial cells. And these are the histological patterns of spermatogenesis. Among the study group, non-obstructive azoospermia was defined as Johnson score less than 7. Obstructive was more than 8 or equal to 8. 12 patients had non-obstructive azoospermia and 8 had obstructive azoospermia. The MRI protocol was done on a 1.5 Tesla MRI system in Genia with a pelvic coil and a circular surface coil. Regarding the MRI assessment, the volume of every testis was measured by creating a 3D volume of interest. The ADC value of every testis was measured by drawing a region of interest about 1 centimeter square in the midsection of the testis. Any pathological process in the scrotum and pelvis was reported. Regarding the results, the hormonal profile, of course, with non-obstructive azoospermia, the FSH and LH were higher, the testosterone was lower, prolactin was higher. There were findings among the non-obstructive group. Among them was hypoplastic seminal vesicles and epididymal cysts, prostatic cysts, with also findings among the obstructive azoospermia group. We will go through them with the cases. Regarding the comparison in ADC value between obstructive and non-obstructive, the obstructive cases had a lower ADC value, and there was significant difference in the ADC value among obstructive and non-obstructive cases. Regarding the ADC value, of course, the high ADC value was for the non-obstructive azoospermia because the abnormal spermatogenesis causes the testis to lose its diffusion restriction. Among the volume, in comparison between these cases of obstructive and non-obstructive, the non-obstructive cases had a lower volume with atrophic testes. The cutoff value for ADC was 1 with a sensitivity of 85%, specificity of 70, and it was significant. So ADC value below 1 was for the obstructive azoospermia. And this is the ROC curve. The testicular volume, there was a cutoff value of 13.17 to differentiate both cases, which was highly significant. So a value above 13 was obstructive azoospermia, below 13 was non-obstructive. And this is the ROC curve. So the diagnostic accuracy of MRI in this study was 100% sensitivity for differentiation between the two cases, and specificity 83% with accuracy 90%. Case 1 was a 41-year-old male with azoospermia, normal hormonal profile, low semen volume. He had history of undescended right testicles for which he did orchidopexy when he was 5 years old. So we're going towards normal hormonal profile, towards an obstructive case. On examination, he had atrophic right testis and normal-sized left testis. Testicular biopsy showed from the left testis showed normal spermatogenesis, which is the normal testis. MRI examination showed absent left seminal vesicle, left vas difference, atrophic right testis, and ectopic left kidney. Now we can see here, this is the normal right vas on the right side of the pelvic cavity where it goes to join the seminal vesicle, and this is another cut for normal vas, and there was absent vas on the left side, congenital unilateral absence of vas. This is a coronal image, and this is the right-sided vas, and here is its continuation joining the seminal vesicle. On coronal and axial images, we can see here that there's an absent left seminal vesicle, and right seminal vesicle appears to be normal. Here is the atrophic right testis, and he had also segmentation anomalies of the vertebrae with remarkable scoliosis. This is a companion case for congenital unilateral absent vas. This is the normal vas on the left side, and this is where the vas is absent, and it's usually associated with right-sided renal anomalies. Here it is agenesis. Congenital absence of vas could be unilateral or bilateral. These are a common cause of obstructive azoospermia. Up to 82% of patients with bilateral absent vas have mutation within the cystic fibrosis gene. This is a companion case for seminal vesicle agenesis, complete bilateral seminal vesicle agenesis. It should be seen here. Seminal vesicle agenesis could be bilateral with mutations also in cystic fibrosis gene. It is associated with bilateral agenesis of vas, and patients have normal kidneys. Sometimes it is unilateral seminal vesicle agenesis, and it is associated with ipsilateral renal agenesis anomalies. Case 2 is a 20-year-old man with azoospermia, low semen volume, normal hormonal profile, again going with obstructive. The testicular biopsy was for obstructive azoospermia. MRI showed average volume of both testes, and low ADC value with a prostatic utricle cyst. Here we can see a midline cyst in the vicinity of the prostate gland. And here is an axial image with a high T1 signal denoting proteinaceous content. So this is an obstructive case. This is a companion case for a prostatic utricle cyst from the literature. Prostatic utricle cysts are located in the midline, endodermal in origin, communicate with the posterior urethra or ejaculatory duct, so usually contain spermatozoa. They do not extend above the base of the prostate, remain confined within prostatic boundaries. Typically, they are smaller than Mullerian duct cysts. They're not larger than 15 millimeters. Mullerian duct cysts result from failure of Mullerian ducts to regress, can cause saccular dilatation. It affects 55% of males with azoospermia. These are located in the region of verumontanum. They extend beyond the prostate and lateral to the midline, and they are best demonstrated in the sagittal image as an inverted water droplet-like shape. And this is a companion case from the literature for a Mullerian duct cyst. Case 3 is a 39-year-old with infertility and azoospermia. On examination, bilateral atrophic testes were found. Testicular biopsy revealed Sertoli cell-only syndrome. On MRI, bilateral low-volume testes, high ADC value, prostatic utricular cyst was found. And this is the utricular cyst on axial and coronal images. And this is the ADC value for both testes. It's above 1, 1.1, and 1.2, and low volume of testes. So this is a combined case. Case 4 is a 39-year-old male complaining of infertility with painful ejaculation. Semen analysis revealed azoospermia. Testicular biopsy showed normal spermatogenesis. MRI revealed normal volume of both testes, low ADC value, large ejaculatory duct cyst. And you can see here a cystic structure compressing both seminal vesicles, and it had also high proteinaceous content, and it had a communication with the prostatic urethra. This is a companion case for an ejaculatory duct cyst. It is usually paramedian in location. So they are rare but surgically correctable cause of male infertility, and in these cases, the volume of the ejaculate will be low, the hormonal profile will be normal. On MR images, the ejaculatory ducts are cystic, thin-walled, in paramedian location, and sometimes have usually low T1 signal, sometimes high T1 signal. Case 5 is a 34-year-old patient with azoospermia, normal hormonal profile. He had underwent left-sided varicocelectomy. Testicular biopsy showed hypospermatogenesis. MRI showed left-sided varicocele, so it was recurrent, bilaterally dilated distal vase, and low testicular volume. So the varicocele affected the testicular volume in this case, and this is the image of the varicocele, and this is the low testicular volume, was about 7 ml. And these are the dilatation at the ampulla of the vase in its continuation with the seminal vesicles. Case 6 is a 33-year-old male patient with azoospermia. Semen analysis showed low fructose, consistent with obstruction below the seminal vesicles. Testicular biopsy was normal. MRI showed bilateral seminal vesicle hypoplasia, and this is the image for axial images of the seminal vesicles. This is the site where it should be, and it was not seen. It's only some small cystic spaces at this site. So this is bilateral seminal vesicle hypoplasia, and this is a companion case for seminal vesicle hypoplasia. Case 7 is a 30-year-old male, azoospermia and elevated hormonal profile. Biopsy showed Sertoli cell-only syndrome. MRI showed low volume and high ADC with right-sided hydrocele. And this is the low volume of both testes, and the ADC is 1.1, so it's higher than normal. To conclude, testicular volume and ADC values are useful parameters to distinguish obstructive from non-obstructive azoospermia. In our study, based on testicular volume and ADC, a cutoff of more than 13 and less than 1 was able to make a diagnosis of obstructive azoospermia with a sensitivity 100%, specificity 83%. MRI combines the most important features of scrotal ultrasound and TRUS, giving information about testicular volume and also seminal tract abnormalities with an added value of functional imaging. Recommendations: larger studies with large number of included patients with azoospermia are recommended. We recommend that MRI examination to be performed before testicular sperm extraction to be able to assess if MRI parameters can be useful to predict successful sperm retrieval. We recommend the application of other parameters of MRI like diffusion tensor imaging to test the diagnostic performance of these parameters for differentiation between obstructive and non-obstructive cases. Thank you.
بشكر دكتورة علياء على البرزنتيشن الجميلة. أنا بس ليا استفسار واحد على الاي دي سي. يعني الاي دي سي اتس نوت ذات اكيوريت عشان الاوفرلاب بتاع النمبرز بتاعتنا. وانا شايف ان الحالات اللي انت شخصتيها على اساس انها نون اوبستراكتيف واوبستراكتيف كان الفاريابيلتي انت بتتكلمي على 0.1. فاز ات اكيوريت ان انا اقول ان الحاله دي اوبستراكتيف او نون اوبستراكتيف لو الاي دي سي 1.1؟
هو based على ADC alone you cannot diagnose the case، بس هي بتبقى the whole clinical picture مع ال findings بتاعت ال obstructive مع كمان ال transrectal ultrasound. يعني ADC alone هو بس ممكن يبقى assistance في diagnosis وهو لسه under experimentation، لكن it's not enough alone طبعا. عشان وعندنا كمان في الستادي كان في overlap في ال ADC values، يعني كان في overlap عالي.
طب يعني I can recommend testicular biopsy if the ADC is above 1
مع الفوليوم. yes you can recommend طبعا. اوكي
ميرسي جدا.
شكرا دكتور علياء.
نعم.
I have لا لسه I have 2 questions and 2 comments. As regard the case with unilateral renal agenesis, was there ipsilateral seminal vesicle cyst?
The first case with renal agenesis no ما كانش فيه. كان فيه the same site كان فيه seminal vesicle agenesis. agenesis على الليفت. وحضرتك تقدر تقصد الفاز absent vase؟
No. The other case was unilateral renal agenesis and maybe absent vase.
Yes, this was absent vase, absent left seminal vesicle, pelvic left kidney.
Yes, if you have renal agenesis and ipsilateral seminal vesicle cyst.
It would be Zinner syndrome.
Yeah, so you suggest Zinner syndrome.
Yes.
We have many cases with subfertility have this syndrome.
That's why these cases you should do coronal for the abdomen always. Yeah.
Okay. The case with prosthetic utricle cyst. Was there history of hypospadias or repair of hypospadias?
No, there was no history of hypospadias in any of the cases of prosthetic utricle cysts.
Yeah. In your comments about prosthetic utricle cyst, you have, it's recommended to add, it is common in
association with hypospadias.
Association with hypospadias.
Yes, it could be associated.
Okay.
Yes.
2 comments about also the citation. You didn't mention the journal name.
The journal, yes.
Yeah. And in regarding the figure legend, you said like 45 years old patient, it should have a dash after 45 and year without s year.
Okay.
Not years, yeah.
Yes, okay. Thank you.
For writing either
45-year-old with
article
dashes.
or on thesis or.
Yes.
No, thank you.
Okay, thank you so much.
So it's my pleasure to introduce Dr. Rasha Salah.